Yep.
Go
All
for
right.
it.
So we'll go ahead and get started. Hi to the both of you. Thank you for joining us. We'll start with some introductions of our team, and then we'll talk to you a little bit about what inspired us to talk about this topic. So just to start things off, my name is Kriti. I wear two hats this year. I'm both a pediatric emergency medicine attending at CHOP as well as a simulation fellow.
And I'm Julian. Just one role at CHOP. I'm one of the first-year fellows there.
I'm Ellen Slabowski. I'm one of the PEM attendings there. Been for the past 11 years, so but I'm not a CHOP lifer, so it's a thing.
And our last team member couldn't join us today, unfortunately. Her name is Dr. Anna Weiss. So just to talk a little bit about what inspired us to talk about this topic, essentially, when we think about simulation and how rapidly expansive it's been in the field of emergency medicine, it's really impressive how it's reached a lot of different groups of people. You've got, your pre-hospital staff, your nursing colleagues, physicians, of course, students of all kinds. But we think one group where there's still a lot of opportunity for it to reach is caregivers. And so that sort of inspired us to put this together. And hopefully at the end of the 20-minute session, we'll have your minds churning a little bit about how to pursue some creative simulation options to educate caregivers.
Perfect. Welcome. So we're going to jump right into a case that I am sure you guys have all seen multiple times in your emergency department. So just imagine you have a 5-year-old Timmy who was playing with his brother. He slipped and then hit the side of his head on a cabinet and sustained a scalp laceration. He otherwise looks super well. He did well with the clean out. He did well with the staples. And you say, why don't you follow up with your pediatrician in 1 to 2 weeks and get these removed? Mom realizes that there are no openings for the pediatrician, so can't get the staples out, received no simulation, no instructions kind of on how to get these out. And so ended up having to come back to the emergency department to get these out. She has a 2-hour wait, both her and Timmy. They miss work, they miss school. And then this was uncompensated. And then they needed to take public transportation just to add an extra layer of complication to their ED visit. But now imagine if that scenario had gone a little bit differently. So imagine that we had a nursing educator who was there that day at the emergency department and was able to provide the family with a simulation model and practice and resources, and actually gave them a staple removal to use at home and taught them how to use it. And instead, we're now not missing work. Timmy was able to go to school. He got his staples removed by mom and did great at home. So with that case in mind, we wanted to talk about, some questions, and this is pulling up here. Okay, good. So some of the challenges and needs of caretakers at home, kind of what are the benefits of teaching simple aspects of a child's care at home, and how can simulation be leveraged to target these gaps and improve outcomes for both caregivers and healthcare facilities. And
So this is the
this
interactive
is the
part where the whole big group gets to discuss with their neighbors. And we were originally going to have you guys discuss and then come back to the group. But since we are the group, why don't we just discuss out loud?
Yeah.
What are some kind of challenges that you think you would encounter when dealing with a caretaker if you ask them to do some sort of procedure at home?
They're scared.
Right.
Mhm.
They're scared. Yeah.
They've never done it.
Totally.
Never done it. Yeah.
Yeah.
You can show them how to
Mhm.
do it. You have time to do it. It's something as simple as that.
Yeah.
Mhm.
Oh yeah, they have like lots of stuff going on. Like they're waiting for the bus, the Uber. And you just did something. You're trying to teach them something. Half the time they don't even read our AVS or remember what it says. And now you're asking them to do something they've never done before. So yeah, there's a lot. I can see where there'd be a lot of pushback.
And also, I think we're very mindful in the emergency department about having the parent be the parent and not the caregiver, like the medical caregiver. Like we don't have them pulled for a procedure, right? So now if we're asking them to do something that we would want their doctor or a doctor or a nurse practitioner or somebody to ideally do, then does that blur the lines?
Yeah. It's a really good point. Benefits we kind of alluded to a bit, but saving time, saving money, but there are also some downsides that you also talked about. And then kind of like what simulations, what kind of procedures do you think would be possible in your facilities?
I teach parents how to produce nurse aids.
Cool.
Amazing.
Yeah.
Like, because they can refer.
Mm-hmm.
I show them.
Mhm.
visit.
Yeah, I do the same.
Great.
Staple removal is as good as
Yeah.
reasonable.
Mhm.
I think seizure removal could be as well.
Mhm.
It's funny, I actually usually do give the staple removers to my families, and I always have to look at the dads. I'm like, this does not mean you get to do it at home. You still have to follow up with your doctor.
Yeah.
Because sometimes the PCPs don't have the staple removers,
Yeah.
but you know the dads are like, can I just do this myself?
Yeah.
Yeah.
Exactly.
Cool.
So then we were just going to give you guys a little bit of a roadmap of kind of what we were going to chat about today. So first, which is kind of the bulk of what we're talking about. So what has research already shown in this area about what factors lead to gaps in knowledge for caregivers and what challenges they face at home. We were going to talk a little bit about our stats and kind of what we thought about as our kind of like low-hanging fruit, so sort of where we could introduce simulation to kind of help save some of these visits and teach caregivers things that they can do at home. And then next steps and new ideas that, we'd love to hear from you guys as well.
Cool. So before we do anything like create a caregiver facing simulation, it's really important for us to go into the literature and look into things like what are their actual needs, what's been cited out there as evidence, as well as what are their challenges. And so I went ahead and did that, and there were some themes that I'd love to go over that kept popping up, and I'll go one by one. So number one was really being able to tailor information to personal preferences. So being able to ask families, especially if there's certain cultural customs or personal preferences they have, asking things like, how are things done in your home? And being able to tailor that education to them as you're simulating any form of education. That will go a long way in addition to things like number two, considering the importance of community. Luckily, a lot of parents and caregivers do not operate alone. They have that village behind them. And these are, other parents, neighbors, family and friends. And so this becomes important for two reasons. One is the fact that it's important for you to formulate a sim where you know that your effects are actually going to reach an invisible group of people outside of the parent you're educating. And I think that's really powerful. And then two, being able to tailor that sim to involve other people who are going to be involved in their care, in addition to caregivers, direct caregivers. And I think that will help, tailor things even further. Three would be offering alternative strategies. So parents seem to love when you give them option A, but you also give them option B and C in case option A doesn't work. And especially if B and C are, let's say, more financially favorable for whatever reason. So they like having a couple different methods of doing things before they realize that they may actually need some help. They may need to, unfortunately, go back to the ER or call their PCP and so on and so forth. 4 is really simple, but definitely worth stating. Somewhere in your simulation, if you can find a way to really make them feel empowered, that is going to go a long way. And that seems to be very pervasive in all the literature I looked at. So definitely thought that deserved a little bit of limelight. And then similarly, 5 would be validation of challenges, right? So being able to really anticipate some of their fears, as we alluded to earlier, and being able to say things like, hey, I understand if I teach you how to reduce that nursemaids, you might be a little worried you might be hurting your child. Here are the things to look out for and stop if you see these signs, and here are times to continue and keep going. And so being able to allude to that is very important as well. And going from, caregiver needs to now looking at literature covering caregiver challenges, I wanted to point out a few powerful words about descriptors of challenges that came up. So these were words like parents use the word daunting, overwhelming, they felt anxiety-ridden and powerless. And when you think about the fact that most of these parents are not from the medical field, familiar with the medical field, and now you're asking them to do something in a field they're unfamiliar with direct impact on the care of their child, I would probably use these words too. So I think that's really important for us to be aware of as we formulate any caregiver-facing sim. Number 2 would be things like mastering routines. That is a big challenge for parents, especially if they're first-time parents or parents of young children. Habit building can be a really important part of forming a sim. Anytime there's a topic that you think may have a habit behind it, so such as routine, cheat tube changes every couple months, and things like that. So being able to tailor sims to cater to habit building would be really important. And then lastly, talking about the burdens of care. This is a really big challenge for parents. And when I say burdens, that's a really big umbrella term. It lists things like financial burdens, emotional burdens, physical burdens. Being able to allude to some of these burdens, understand them, and try to tailor your sim to counteract them is going to be really important as well.
All right. We're talking more in this breakout session, discussing as a group. And we kind of talked a little bit about this earlier. You had mentioned nursemaids as a possible option. We talked about staples. Are there any other kind of low-hanging fruit that you can kind of... Yeah,
Great.
I love that. Mm-hmm.
To a lot of that.
Rescue benzos, like.
Yeah.
Benzos, yep.
Yeah.
That's a great one.
Just how to manage a seizure, what do you do?
Mhm.
Yeah. G-tube, NG.
Yeah.
You know, a lot of times that takes place more in the inpatient, but how many times have you had a parent come in and they're like, oh, I'm just too nervous to do it myself? They're like, I know I was taught, but I'm too scared to do it. So obviously we as a collective failed somehow to empower these families to do that. And I would never fault them for coming back in. I'm always like, if you're never comfortable, come on, I'm here 24 hours a day. Like, come on in. But like, this is something that we can do. I also tell the residents that when they're like all freaked out, I'm like, listen, parents change trachs at home. Parents with no medical knowledge change trachs. You as a third-year peds resident can change this trach. Yeah, empowering everyone. So that was kind of talked about 1 and 2. And then what kind of resources can you use? Like you have EpiPen trainers, I assume, for that. How do you guys, or do you know how do your nurses do the benzo training? Do they have, is it a video? Do they have models? Do they have?
No,
Yeah.
I just verbally.
Yeah.
I know.
Yep. Yeah.
It's a lot of verbal. Yeah. But we probably can expand on all those things. You know, if they have a tactile feel, they're going to feel more comfortable than you just talking to them. All right.
So before we end the talk, we thought it would be fair to at least just get a sense of what happens at CHOP in terms of some of these common things that we see that seem to pop up in the ER all the time that may actually be addressable with things like caregiver simulations. So we came up with 3, and I think all of those have been discussed. Nursemaids' elbows, G-tube dislodgements, and scalp flats. So just to run you through some of our numbers and full disclosure, I think that these numbers are probably lowballed because ICD-10 codes are just hard to capture in Epic. But we came up with, in the year of 2024, 509 visits for nursemaids, 132 for G-tube, which we think is the especially lowballed one, and then 287 visits for scalp lacerations. And the reason we thought this was important was because we're looking at this as our avenues for opportunity. So yes, not every G-tube dislodgement is going to be a quick, easy, and simple repair that can be done at home. Some may require surgical consultations at bedside in an ER, but it's safe to say that some of this very low estimated number could probably be handled at home. And similarly, when you think about scalp lacerations, if we had 287 people with staples in their head when they walked out of the ER, 287 opportunities for someone to take those staples out, and that someone could very well be a parent. And then lastly, with nursemaids, 509 visits, clearly it's a very popular reason that kids come to the ER. But like you mentioned, with the rate of recurrence, even the most conservative rate in literature being like 5%, that's still a handful of opportunities for parents to try again at home. Or maybe if, a sibling has it later on, a second sibling, they would know what to do the second time. And so lots of ample opportunities there. So this is what we captured in the year of 2024, and that was really insightful to us because it gives us a sense of what directions we can move in.
Did you purposely look these particular 3 up?
Just because we felt like they could be potential good topics to address with caregiver simulation.
Exactly. And then just going to talk about kind of what we thought about as our next steps. And this first one in particular is one that I think is specific to CHOP, but also at bigger children's hospitals where they have family learning centers. I think these are most utilized by our kind of chronic medical children, where they learn things like urine catheterization, trach changes, all these kinds of different procedures, and a lot of medicalization that they end up doing for their child at home. but that this same resource can be leveraged for children who are healthy. Because a lot of them, for example, for catheterizations, they'll use dolls, and they offer both virtual and in-person options. So if it's a resource that we offer for families to use who are interested in doing this at home, another way for them kind of to learn to do this procedure at home and save an ED or a pediatrician visit, especially if everything is going really well at home.
Do you have this resource through the ED?
They don't usually come down to the ER.
Mhm.
I've spoken to them recently. They don't have the resources to do that, but they do have lots of telesimulation options. They have dolls that they can use to essentially as mannequins for like G-tube assisted children and things.
Yeah.
And their website has videos about like G-tube replacement, trach replacements that can be accessed by the parent. So even if a family was uncomfortable in the ED, we could always direct them to the website and they can get some just-in-time training, and then they can always make an appointment and kind of see the learning center at a different time.
So available for our ED patients, but like not for them to come down and teach them.
Usually what will also happen is that if a child is scheduled for a G-tube procedure, before they leave and get discharged, they usually do have an appointment with the Family Learning Center for a training session before they go home.
And then the other thing we were thinking about is that at most of our hospitals, adult, both and pediatric, we already have simulation resources in place. And some of these can be as simple as, like, I think of like the first time I learned how to do a laceration is that mat you get from Amazon, and you make the cut on it with a scalpel, and you get that kind of just-in-time teaching before you go do it on a patient. But imagining that same scenario instead, where you do that and you put staples in that mat, and you ask that parent to take the staples out of that mat, and that's kind of their teaching that they can try before they actually do it on their child. So another option for parents to try to feel more comfortable at home. And the last we've talked about and alluded to, but all families kind of when they leave the emergency department have these after visit summaries and get QR codes for all kinds of videos and everything, but can incorporate into those videos on how to do some of these procedures at home if they need, again, that just-in-time teaching, or that's the first time they're learning how to do it and they want to take the staples out at home or reduce that nursemaid elbow, just so that they have access to something so that they feel like they have a resource when they're trying it at home. So we'd love to hear from you guys, things that you guys do, because it sounds like you guys already do some kind of teaching. It sounds like a lot of care with benzos, with nursemaids. It sounds like you guys have thought about this too when discharging your
I
children.
thought of
from the
one
emergency
more.
department.
You know, it's a low frequency, high stakes thing, but I think especially for kids with like complex medical conditions, actually teaching bystander CPR.
Yeah.
Mhm.
There's an evidence base that it actually improves survival.
Yeah, and I've seen, I came from Pittsburgh, and it was a family, they did it, they would go to all the high schools, and one of the people she taught, 1 week later, her dad collapsed at home and walked out of the emergency department. Or out of the hospital. He was admitted, obviously.
I don't discharge people like
No,
that.
not people who need
If you get chest compressions,
Yeah,
you might
yeah,
admit it. But baseline. What do you guys think about like liability? And we didn't really talk about this.
Yeah.
But I started talking about this. If you're asking parents you're not making them do it. I'm always saying like, this is an option. Is there any liability when it comes to those things?
Liability is shared decision making.
Yeah.
Right? And
Mhm.
you know it, then you just document it.
Mhm.
Yeah, nicely shared decision making on my documentation.
Mhm.
For scalp lacerations is also the education component of like making sure they don't, you know when it's infected or not healing properly, you know, so I think there's more to that education than just
I agree.
Taking them out.
staples,
Mhm.
because we inspect it before we pull it out, right?
Mhm.
And
Absolutely.
sometimes they come in too early, we're like, oh, that's not ready to
Mhm.
come out,
Mhm.
you know, and so, but do the parents know? Like,
Yeah.
and so just, like, I think there's multiple levels of like, you know, understanding that they may not get in like one session of one teaching.
Great point.
And you know, I've talked about this topic in a few different avenues at this point, and one of the most challenging questions I've probably gotten is probably from someone with more of a hospital administrator hat, saying things like, "Well, why do we want to prevent these visits?" So wanted to pose that out there
Yeah.
and see what
That's
people
true.
thought.
Staple removal is a
Billable procedure.
billable procedure.
So
Yeah.
Service.
Yeah.
Is it okay for somebody to wait 2 hours to get staples
Something's wrong.
Right, and then you lose the shop brand.
I know,
Or
right?
lose the Stanford brand.
Yeah.
Right, and
Yeah.
is it worth that, I don't know, $10 that we're going to get back?
Yeah.
You know, there's something, are we doing better for the brand by empowering the families?
And I mean, my answer is really also just to add to that, you're allowing the hospital to dedicate and allocate resources to the sickest patients first and not putting stress on the system, especially when you have a waiting room full of, 30, 50 patients out the door, and one of them happens to be a procedure like this that could have potentially been handled at home. And so there is something to say about that as well.
I mean, in the end, if the family feels capable, feels empowered, we're not, and we can help alleviate the fear, then it's a low risk.
Mhm.
Mhm.
Journey.
Mhm. Definitely.
You're okay.
Yeah.
It's okay, but as you said, we're here for protect.
Mhm.
Always here to offer that support. And then there's also, we can do telehealth
Hmm.
follow-up visits.
Hmm.
And so this is something that we can leverage,
That's a good point.
having the telehealth visit at the same time as.
Yeah.
But allowing families to do the procedure.
Yeah.
Yeah.
For that, we had that at Pittsburgh too. We had a
Telehealth,
telehealth
yeah.
through the ED. Awesome.
Thank you so much.
Thank you
Yes.
guys. Yeah.
Thanks for coming.
Yeah. Thanks for participating. And Sean.
This was a great